Good afternoon, everybody. My name is Stephen McBride. I'm the Director of Services at youre, and I'm delighted to welcome you all along this afternoon for our monthly webinar series today. And the topic of today's webinar is going to be understanding the impact of trauma. Today's guests, and I'm delighted to welcome along two guests who have a great understanding from both a research, academic and practical perspective on trauma and its impacts and its legacy. So I'm really looking forward to the conversation between the three of us this afternoon. Our guests are Dr. Sharon Lambert, who is a senior lecturer in applied psychology at the University College Cork, and Dr. Alan McDonnell, who's a chartered counselling psychologist working as a senior therapist at the HSE National Counselling Service. So I'm really delighted to welcome you both. And I'm looking forward, as I was saying in our preparation for this webinar, to the conversation together this afternoon about understanding the impact of trauma. We'll have time for all the audience who have joined us. We won't be able to get to everyone's questions or comments or observations, but I'll do my best to field as many questions as I can to our expert panelists this afternoon. So without further ado, I suppose if I was to invite you, first of all, Sharon, to talk a little bit about what your understanding is in terms of the work that you do of the impact of trauma on people's lives and maybe even in society more generally.
Thanks, Stephen. I suppose I'm going to roll backwards a small bit and just start off by saying, like, what is trauma? Because that's something that's a changing understanding. So there's no one clear definition of trauma in psychology, for example. And some people can view, trauma as a very obvious things. A lot of the kind of work that Alan does, for example, with people who've experienced abuse. Then there's also trauma such as the experiences of racism and discrimination. So there's a better understanding around that now. Some people might argue as well that things like experiences of poverty can be such a toxic stressor and can have an impact on somebody's development that perhaps, is that a trauma? So I suppose that's kind of where I wanted to start with, was saying that trauma is a unique individual experience, and what one person might experience as a trauma, another may not. And it's something that we are, understanding and moving along with all the time. So in terms of its impact, it can have a profound impact on people. I suppose a lot of the work that I do would be around the relationship between trauma and addiction and homelessness and other social harms. So there are people who've experienced trauma who can function, who on the outside maybe feel like they're functioning quite well. And then there are some people who've experienced trauma where, they lose everything and they end up experiencing a lot of disadvantage.
Indeed. Thank you for those opening comments, Sharon, and to bring us back into a sense of your understanding of what trauma is, and obviously in your description of it, talking about addiction and mental health and racism, disadvantage and poverty, you can see the social factors that both influence trauma and are a result then of trauma leading to those situational and social factors and being a consequence of it. So thank you for those opening remarks. And in relation, if I was to come to you, Alan, for your maybe opening comments in relation to your understanding of trauma and its impact.
Yeah, I suppose very similar to Sharon, and maybe just to roll back slightly as well, my experience. So again, Sharon's spot on in the sense that my experience comes from people who I have worked with as a clinician who have experienced some form of trauma in their lives. And there's varying degrees of trauma, absolutely. I suppose the literature would say there's big T's and small T's in terms of major traumas and little traumas, but nonetheless, they still can impact somebody. So my work originally began a couple of decades, a little over a couple of decades ago in addiction as well. And very similar to other, people who have worked with the cohorts that Sharon was talking about, I realized quite quickly that most people who end up in rehab or in recovery from addiction or seeking recovery from addiction when you look at their history, they've pretty much I haven't really, I mean, I'm sure there is an exception to the rule, but I haven't really come across anybody who hasn't experienced trauma of some kind in their past. And therefore, the addiction piece would be a coping mechanism against the trauma. So I would see then, that led me on to becoming quite passionate about working with people who've experienced other forms of trauma, especially in the National Counselling Service, where we work with people who've experienced trauma or abuse as children. So that can be neglect, physical, sexual, emotional abuse as children. I suppose to get back to your question, my absolute definition of it is it's back to the original kind of etiology of the word. It's a wound. It's some sort of spiritual or soul wound that happens to a person when they experience hurt as children, generally speaking, and I like the definition that's currently kind of, I suppose, espoused by most of the experts in trauma, is that trauma is not necessarily the event that took place, but what happens inside us as a result of the event. So it's how we process those big T's, those little T's, those attachment traumas, or those one-off events that can be really harmful.
Yeah.
That's how I probably view trauma.
Thank you, Alan. Thank you. That's a great response in terms of your understanding of it. And I suppose listening to you both, and the sense of the social in it, the psychological impact for an individual, but then the social factors involved in perpetuating or developing trauma, in different societies. And I suppose we're speaking about, you could have a global worldview on it, but also putting our own lens within Irish society and thinking about that too. And I think we'll have time to touch into that this afternoon together. But Alan, if I was to come back to you for a minute, what would you say if you were to give some examples of small T's and big T's in a general sense, without kind of creating too easy or neat a category for it?
Yeah, I mean, the reference guide that I'd go to is there was a study, there was a doctor, I think back in the 1980s, the late 70s, 80s, Dr. Folletti, who was working in a clinic for obesity in California. And he discovered, very similar to kind of my anecdotal discovery, that people who ended up in that obesity clinic had what he described as adverse childhood experiences. So basically then they did a lot of research on that afterwards, and the Center for kind of Disease Control took over a massive piece of research on that and discovered that, there are 10 kind of real impactful pieces that affect us. And these are called ACEs, adverse childhood experiences. One of them is probably a small T. Well, not necessarily, but cumulatively they add up to big T's. Now, a small T can be something like rejection of a primary caregiver, or being undermined by being bullied, being ridiculed in the family home. And then, of course, a major T would be something like a sexual assault or physical assault, or even something like non-abusive, like a major illness, accident, car crash, death, loss of a loved one. They can be major T's.
Yeah, that's very helpful. Thank you, Alan. Thank you. There was one of the points that I wanted Sharon to tease out a little bit, and there's a lot of commentary on it, I suppose, and it'll be very helpful in terms of our audience here at the webinar to get a bit of an understanding of what we mean by trauma-informed care, and having that lens, or that supporting someone who has experienced or experiencing trauma.
So there's a lot of conversation now about trauma-informed care, and I suppose some people are worried that it's a buzzword, and that it's meaningless, but actually it's very important. So Alan talked there about those big studies that were done by Felici et al. In the Center for Disease Control, and there have been thousands and thousands of studies done since then all over the world in loads of different groups. So what we do know is that trauma is not as uncommon as we would like it to be. Lots of people experience different types of traumas, and some people struggle, you know. So what that might look like is that they find it hard to kind of regulate their emotions. So, you know, if I've experienced traumas and I go to use your service and I'm left sitting in a very noisy waiting room with no sense of how long I might be waiting, you know, what kind of memories might that be connected to that might feel scary to my brain. And if that happens, then my brain is going to scan the environment and say, this is a dangerous environment. It's going to activate my fight or flight response system. And then I might leave before I'm seen, or I might get cross. And people will look and they'll say, she's very difficult, she's very challenging, and she's very angry. But I'm not. I'm frightened. And I'm doing exactly what I'm supposed to do when I'm frightened, which is activate my fight or flight response system. So the problem for a while with a lot of service provision is that we don't always provide a service for the people who need it the most. So often when people have experienced trauma, the impact of trauma is that, you know, there's all of these chemicals released in the body. It's bad for the immune system, bad for developing bodies. So sometimes people can develop physical illnesses as well. So what can happen then is people who can be quite maybe struggling, maybe psychologically, but also struggling with physical health, and really need to be able to access services, and they can't, because the service says, this is how we do it, and we do it the same for everybody. And if you're not able to roll along with those, then it's difficult and you're out. So trauma-informed service design understands the neuropsychology, what happens to a brain and a body when it gets really stressed, and it adopts its service to match that science. Now, there's levels of being trauma-informed. So trauma-informed is an end goal. It can take an organization 3 to 5 years to become fully trauma-informed. Some organizations might never be able to come fully trauma-informed because they might be too large, might have too many different moving parts. Sure. Because a fully trauma-informed service is one where there is a level of awareness and a changing to policies and practices at every single level of the organization. So what you can do is you can consider it a journey. And the first stage is being trauma aware. So a trauma aware service. Then the next step is a trauma sensitive service. And then the next one is a trauma responsive service. And then a fully trauma informed service. So if every organization said, you know, we're going to aim to be trauma sensitive, which is the second along that would make a massive difference to people's ability to be able to use services. And, you know, there can be small things like, and they're not small things, actually. Dr. Donald Moynihan, who's a clinical psychologist, and he did his doctorate in clinical psychology here, and he looked at people, young men who were presenting to A&E with serious self-harm and who left before getting followed up on. And things that some people might not notice were very stressful for them. So it starts at the first point of contact. So they arrive at the door and it's security. And they might look them up and down in a particular way because they're upset, or they, you know, they might look disheveled, or their clothes might not be great. So they feel judged immediately. And Alan spoke there about kind of the impact of rejection. So if they've experienced rejection in the past, then the brain is saying this is a negative experience. Security guards are primarily trained to work on nightclubs, which is an entirely different setup than a healthcare situation. So we would need security to be trauma aware. And then everybody that you meet along that journey, if they were trauma sensitive, we would be able to get people, when they come into our service, to be able to use our services, and then they would be happier and healthier, which means staff will be happier and healthier, because staff can get very stressed out when they're dealing with people who are very traumatized. So
Mm-hmm.
the service users, the staff, and the organization as a whole will function better for everybody who's in it.
Yes, and that's so well described, because it allows, or it's in service of destigmatizing the person who has experienced trauma and is activated in that way or impacted. So that's a real life example, Sharon, you're after describing, of how a person could very well be impacted. And I think I read that study. It was in a recent publication from the Psychological Society. And we're actually doing work in Aware. We're after opening up a new service, a Solace Cafe, which is for people who are experiencing significant crises in their mental health, and it is trauma informed in that regard, from a peer support model. So it's really interesting tuning into that, to be in support of individuals and groups who are impacted by trauma, and providing support in that. Yes, very good. And I suppose, Alan, coming to you in a way around, do you resonate with anything Sharon said in relation to what works best for individuals, or in terms of supporting people? Because, and I suppose I'm tuning into what we do at Aware. We have individual supports and group supports for people who are experiencing depression. And the link, obviously, from between childhood trauma and depression, there's always connect those two constructs. So I suppose from your perspective, what resonates with what Sharon was saying in terms of what works, for people who come forward for support and to talk about their traumas at the National Counselling Service?
Yeah, I wholeheartedly agree with everything Sharon was saying. I think, oftentimes we have clients coming to us who've been, again, rejected by other services or private services that have indicated they're too problematic or too difficult or too complex. And I think, absolutely the setting, like just a very small example, like in our waiting room, we wouldn't have, say, we wouldn't have smells as such, or we wouldn't have noise, or we would try to minimize, because we've no idea what might be a spark for somebody. I'm reluctant to use the word trigger, but it's so often used, but we've no idea. So we have to kind of keep it. I suppose the word safe is the most important aspect of it. And I think I think it's really easy when somebody, say, presents with a very tangible response to their trauma, in terms of maybe a substance issue or an eating issue or whatever, the physical, tangible. But when people present because they've had that rejection, and they're very mistrusting, and they're very suspicious, very understandably so, as a result of that, they haven't had a good experience in the world. So we have to try and provide an atmosphere of safety and stability. Really, that's I suppose, in terms of trauma work for us. It's going back to the Judith Herman model of, that's the step model, and the first part of it, and I think it's advocated by everybody, is we're not launching into their story necessarily. We're not launching. It's about connection, and the initial part of it is about how do we provide a safe and secure place for this person to come to realize, this is a safe space. That can take weeks, but it's absolutely not rejecting somebody because they present in a psychological way that other people would find difficult. We recognize that that's actually just a symptom of their trauma. So we're very much in tune with taking that into consideration, that this is part of it. And the initial number of sessions, it's how long is a piece of string, but for some people it's 6, for the other people it can be an entire episode of sessions where you provide that safety and stability. With that bedrock, I think you can do some really good work. But that can take time.
Yeah, very good, Alan. Thank you. And I suppose the key word I'm connecting with in your last comments, Alan, around connection, and at the heart of that is empathy and seeking to empathize with a person's situation, however challenging it may seem to anyone else. Whether that's in an emergency department or in a care center or wherever, in a community group, whatever the context. And I suppose really, and another resonance I'm having to listening to you both is that desire or importance of trying to provide some containing environment for people who have experienced trauma, because that will lessen, as you're saying, Sharon, the fight or flight response. That'll, to use maybe a language from psychology, that'll seek to soothe in a way, or allow for a person's nervous system to relax, for want of a better word. Yeah. Okay.
And just to come in there, Stephen,
Stephen,
with the study, we talked about there a moment ago about people's experiences of tending any. What was interesting with those men who participated in that study was it was often as they were brought into hospital as a result of a crisis, and an ambulance had arrived, and they would have described their journey in the ambulance as one of receiving great compassion, conversations, connection, and that by the time they arrived in A&E, that after spending time with the paramedics, that their distress level had started to reduce. And then because they're left waiting, or there are those other factors around that Alan has described, sounds, smells, what came up a lot in that study, and it really links to something Alan was saying there as well, as about connection. And this it's going to seem like a small thing, but it's massive, is when people walk past you and you're sitting in a waiting room and they deliberately avoid eye contact. So that made people feel like they were an annoyance, and that they weren't worthy of help, and they already felt quite unworthy. So this was reinforcing their sense of their low self-esteem. So then they would choose to leave. Now, when you're working in a busy environment, you do want to keep the head down and keep going, because if somebody else calls you, it's another demand on your time as a worker. So it's about a trauma-informed service would understand it from both perspectives. So they say, how do we create conditions so that our workers can walk through a waiting room and be able to make eye contact and smile and wave and say, somebody will be with you in a minute. So just breaking that silence and that lack of connection can help somebody feel like they're worthy, they're going to be seen, it's going to be okay. And that piece around connection and empathy, is the most important thing. And creating the conditions where workers are able to deliver that will have such an impact on people who are in a bad place.
Very good. That's well put. And I suppose it's the idea that a person who's experiencing trauma in the here and now, which may or may not be related to past traumas, is validated, or there's a connection sought between the person seeking help and the person providing help to validate or understand that experience, because that will, as we say, that will lend towards reducing the response and soothing someone, or regulating them, to use the psychological word for it, isn't it? Great. There's a few comments coming in, just to share, whoever wants to take this one. Maybe I'll come to you, Alan, for a minute. Around a fear of people, in adulthood, that past traumas may be happening again, and happening to them again, maybe into the future, like the fear or the worry about that, in terms of looking into the future and how they might cope with that, or what they might do to support themselves.
Yeah, I suppose it's a very common theme, and I think if we just bring it back to ourselves in relation to that, I mean, if you were walking through Dublin city centre and got hit by a car, whereas you'd never had that experience before, and then you went to hospital with a broken leg and you recovered, you're not going to walk down O'Connell Street in the same fashion. You're always going to have a little sense of nervousness or anticipation around that. So people who experience trauma, the analogy that I like to use is that the way I envisage trauma is like it's almost like a raging furnace from your past. And it's hot, and it's like, melting, a smelter for steel. And if you get, the closer you get to that, you start to feel the heat. And even though it's in no connection whatsoever to the original trauma, but you're feeling the heat, you will pull away. So it kind of then becomes somewhat of a self-fulfilling prophecy. A lot of work being done currently around mindfulness and trauma. So being able to keep it in the day, being able to kind of, I mean, none of us have a crystal ball. We none of us kind of predict that this is coming down the road, or anything is coming down the road. But I suppose to make it very understandable why you might have those fears, that it would, and if you can use the example of the traffic accident, it's perfectly reasonable for somebody to fear that happening again. But the chances are it probably won't. But it's just, I suppose, normalizing that as well, and being, I really like, there's for those who don't know, there's a very famous or Professor Gabor Mate, who's doing a lot of work in this compassionate inquiry. So just really inquiring in a very compassionate, empathic way as to what's going on for you in the here and now, and realizing that, those fears are justified and warranted, but maybe need to be put into perspective at the same time.
Yeah. So to acknowledge, to understand and validate, and in that compassionate, inquiry informed way, and yet also exploring some maybe of the valid too.
Exactly.
Yeah. Sharon, there's a lot of questions coming in, and just to pick your brains a little bit about where people would find further knowledge or accessible information about trauma-informed care or trauma-informed services, and where would you kind of direct people to start their own inquiries in relation to that?
So SAMHSA, SAMSHA, which is a substance abuse mental health administration, I think. So SAMSHA, SAMHSA, have quite good resources and documents on trauma-informed service design. I'm also writing a book about trauma-informed design that it should be ready around Christmas time. So I would say that that's a good place to start, because they have really good explanations and examples about the different ways that you approach it. There are, if you go, you'll see a lot of Scotland, for example, at a government-wide perspective, are trying to make the nation of Scotland a trauma-aware nation. Cork City is trying to become a trauma-sensitive city. So if you look on Cork City Council's website, they have some resources there as well. So you have, at an individual level, you have organizations that are, trying to adapt and to serve both its service users and its staff better. And then you have, cities trying to do it, and then, whole nations. So they have quite good resources on those. I am going to give a word of caution.
Go on.
Is that sometimes when you look at some of the material about trauma, it can be quite deterministic. So Alan talked about, that 10-item scale that was developed in the CDC. So it says, these are the 10 ACEs. So you might look at that and say, I don't have any of those, but this other really bad thing happened to me. So you can get a little bit worried then and think, oh, my thing doesn't matter. There is no one scale. I think the last time I looked, there was about 28 different scales for measuring trauma. You will not find one that has all of the potential things that could happen in your lifetime that could impact you. The other thing as well is sometimes people look at those and they add up their own score. So we know that, the more trauma you pile on somebody, the more it can have a negative impact Then there are also people who will have experienced 5, 6, 7, or 8 of those who feel like they haven't experienced a negative impact on that. And that's because, not because some of us are stronger than others, it's because we're all beautiful, unique human beings who are individuals. And what can happen is, you know, for example, Alan and I might both experience the same negative event, but it might happen for me at a time in my life that is more vulnerable. So it might be while I'm a child or an adolescent, or there might be other things going on. Like, we know one of the big things we know is poverty is one of the biggest predictors of poor mental health. So if Alan and I are 2 children and we're going to the same school, and I go in the morning and I am coming from a home that has money and Alan has not, one parent is going to be able to get access to services quicker and faster than another. So it's not just always about the event, it's about what else is going on in the person's life that might act as a risk factor or as a resilience factor.
Yes.
Nobody's broken. Nobody is weak. It's just that a set of circumstances can happen, which makes it harder for you to be able to deal with what's happening in that moment.
Yeah, it's wonderfully put. Yeah. In terms of the impact of social factors again, and then back to the idea, Sharon, isn't it, of something that's outside of any individual's control, and how we're shaped by the social determinants in which we are brought up and are born into. Yeah. And then
I think in an Irish context, it's really important that we mention racism and discrimination. So, you know, I am a parent. I have 2 children. My children are white settled children. If my children were traveller children, for example, or from another ethnic group, and if they got sick or they were in an accident or something bad happened, their experience of the way the world treats them is not the same as what other children experience, and that compounds their ability to be able to move forward, you know. And it goes back to something that Alan said earlier about connection and empathy. If you don't have empathy for everybody in our community, you're going to cause more trauma in some communities than in others.
Yeah, and just maybe to concur with that, you know, the original 10 ACEs, they don't include things like racism or bullying or food insecurity or natural disasters or especially currently now in Ireland, the refugee status. None of those are included in the original 10 ACEs. So I totally concur with what Sharon is saying, that we have to take all of these kind of psychometrics, if you like, with a pinch of salt, you know, and that it is completely subjective. And what's really interesting in our work is that 2 members of the same family, 2 siblings, for example, one will experience their attachment as traumatic and the other mightn't. You know, so it's just, you know, how personal and subjective, and not to be dismissed in that regard. I think it's really important.
It's complicated, and perhaps we try to make sense of the world in a general sense, you know, by categorizing and making, you know, to put things in compartments, because it can help, it does help, but I don't, in certain contexts, but in the context of trauma, I don't know how helpful it is in nearly every respect, of course. How would you know if you're experiencing trauma? What's your sense of that? What would be, you know, and again, you know, without getting into too definitive, but in a general sense, you know, the person, the unique individual themselves, how might they know that they were experiencing trauma?
Alan, do you want to go first?
That's a big question.
That's a big question.
I suppose viscerally or physically, I think is the place where most people would initially feel it. It depends really. Like, you know, I suppose a natural response to, like Sharon mentioned it earlier, like we have a survival mechanism within our physiological system and our brain system to respond to trauma. So we have kind of maybe 4 for responses that avoid the kind of the kind of new brain, if you like. So it's just basically when we were living in caves and you heard a rustle in the bush, you didn't know whether it was a saber-toothed tiger or it was a neighbor coming home. So your body went into a response, you know, and the common ones we've talked about, you know, fight, flight, freeze, and fawn. So like somebody who experienced like a trauma and had a fight response, they might experience a lot of irritability in their life. Somebody who was in a flight response might be overwhelmed with worry and concern. Somebody in the freeze mode and would feel maybe a sense of procrastination or stuckness in their life. And then the fawning one is probably a little bit under research, but that would be more like, you know, noticing that you're very difficult to stand up for yourself, maybe a lot of people pleasing. They're all the outcomes of trauma.
Yes.
I think when you're experiencing in the here and now trauma, it's like it's a very unique experience. And it's, as I said, the body will respond, and then how it responds will determine how you process it afterwards.
Yeah. Which
kind of brings me back maybe to just talking for that you know, we put great emphasis in our service on, you know, our therapists being trauma informed and not just general psychotherapy, you know, that we use modalities such as emotion focused therapy or EMDR or trauma focused therapy. You know, it's a specialized field, and you need to it's not just generalized psychotherapy.
Yeah, I understand. Yeah, that's helpful to say that. Yeah, and yet in the specialized field, maybe, you know, in a strange sense or paradoxically, that might lead it to be under thought of, you know, as though that it's specialized, whereas actually a person's subjective experience of trauma may not necessarily lead them to want to or need to go to the National Counselling Service. But yeah, so it's broader than that. I suppose what I'm getting at is that coming away from categories, I suppose, in a sense. Yeah, yeah. I'm just noting that there's a few comments coming in, and unfortunately, because it's a general discussion, I can't get into or am able to address individual questions about a person's experience. But I do hope that the atmosphere in this conversation, or what Alan and Sharon are saying, is providing some sense of both information and, to use that word again, connection to your experience. And I will be able to outline different services that you can reach out to at the end if you are being impacted, as I don't doubt some of you in the audience are or will be by the nature of this conversation. So we'll come to that towards the end of the webinar. Sharon, what is your sense of what we're doing, you know, in the health services generally in Ireland, or whatever comes to mind in terms of understanding and working with people to respond to trauma? Is that working? How well do you think we're doing? You know, yeah.
Well, I mean, I don't have to give a personal opinion on that, because there are plenty of reports that will say how we're doing. So how we're doing is that we have, you know, a lot of waiting lists. So we're under-resourced in terms of counsellors and psychologists. There's a recruitment freeze in parts of the HSE, so there are some psychology and therapy posts that have not been filled. So, you know, that could make waiting lists longer. When you have a system that's under pressure, what can happen then is people can bring in, you know, models. So, you know, Alan spoke there about, you know, some people will need 6 sessions, for example. But there are some people who will need 20 or 30 or 40. And what can happen when we are on limited resources is we say, you know, we're going to operate a model of where you get six sessions, and then we, you know, we finish with you. And that's just not going to work for some people. So, you know, I think they call it the McDonaldization of health services, where you create these, you know, a burger and it all looks the same, and you fire it all out, and thinking that every human being who comes in the door is going to work in the same model. It won't. So that obviously puts pressure on the people who are using the services. and on the people who were working in them. And because people who want to work in helping roles, you know, go into those jobs because they want to help people. And if they go into services that are under-resourced, or are not allowing them to work in the way that they want to work, that's very, very difficult for staff as well. It would be great if we could have more counselling services available for schools, for example, so that we could prevent things happening. A lot of referrals that are made, for example, to HSE, to CAMS, would be considered by some psychologists to be mild to moderate, and therefore not a mental health crisis. So you can have somebody who's waiting for perhaps 9 months for an appointment to be told that they're not bad enough for that service. And then you'll have other people, while they've been waiting for those 9 months, that the stress and the worry has actually moved them from mild to moderate into moderate to severe. So catching people upstream, not everybody needs a psychologist. Actually, most children need one good adult. So if we have teachers who are properly resourced, who are trauma sensitive, and who are able to get access, you know, quickly, for children and their families, so that issues can be dealt with before.
Hello?
I think Sharon's lost there. Could I just come in and maybe as we're waiting for Sharon to get back on?
Yeah, go ahead, Alan. Yeah.
Just to, I suppose, just to clarify, when I mentioned 6 sessions, it was 6 sessions for stabilization. Like in the National Counselling Service for our trauma work, it would be at least a 25 session model, is what we'd offer. But it can take, to create that safety, it can take that length of time to create the safety, the 6 to 8 sessions, just to create, and then you may get into the processing of the trauma. But the initial 6 sessions may be just to organize the or create a facility of safety and stabilization in it. So we don't offer a 6 session model, just maybe.
I understand. Thanks, Alan. Thank you. In a sense, from your experience of working with people who have experienced adversity and significant adversity in childhood and in relation to trauma and abuse. Hello, you're welcome back, Sharon.
I was not struck by lightning. There was it was just very quickly, for a second there, the power went, which of course switched off the Wi-Fi. Yeah.
Okay, well, you're back. Good to see you back. I just was going to ask Alan a question, I suppose, in terms of what do you notice are the, I suppose one of the big things we try and do in Aware is to increase access to people out there experiencing depression and bipolar disorder and anxiety and other mood-related conditions, access to the supports that we have. So what is commonly said, Alan, by people, you know, on the cusp of coming forward to help, that they might pick up the phone or send an email, in terms of how, like, I suppose what I'm getting at is how would you say you would encourage someone to seek help or to go for counselling? What are the kind of most important things about removing those barriers, I suppose, is what I'm getting at.
Well, I think one of the misconceptions, if you like, is that it was in the past. What happened to me is in the past. It shouldn't bother me today. So I need to man up or woman up and get on with my life. But the realization comes then, actually, I'm not functioning very well. My relationships are not working the way I want them to work. I find it difficult. I find so many difficulties in my daily life. And it's the that's why I really like that kind of like description of trauma, is that the event may have happened 20, 30, 40, 50. We've people in our service at the moment in their 90s. May have happened to them 80 years ago. But what happens inside continues. So yes, maybe 80 years old, but how it was processed and how it was held, and what Sharon talked about, how the body and the visceral reacted to it, can cause, you know, just so many complications, both emotionally, physically, connectively, you know, throughout their life. So it's not just in the past, and it's not just about getting on with it. It's about actually you're carrying it, even though it might have happened a long time ago. You're still carrying it. And I just to pick up on one point that Sharon made, and I think it's so important, is that my personal belief is that if we see the likes of interventions such as, you know, in schools, I'd be a big advocate of addressing, you know, and I know in America after the ACEs study they do that, but it's like catching some of those pieces early on. It's actually so cost effective because, as Sharon pointed out, if you like, if say you have 4 or more ACEs, you're probably twice as likely to have cancer. You're probably, I think it's 8 times more likely to have a knee or a hip replacement if you have 4 or more ACEs. So the knock-on effect on the health service is massive. So if we can intervene at a counselling level, we're actually saving money further down the line. And I think there's a nearsightedness around that, is that actually counselling is cost effective, and it's
There's a great argument. There's a lot of people around health economics writing about that and researching that. I think there's a bit going on in NUIG out in Galway in that regard, you know. A final few points just to bring up. I'm conscious of time. We've got a little bit of time left. You know, in terms of Irish society, you know, it's often remarked that in our society that we suffer generational or intergenerational trauma. And I suppose as a post-conflict society, you know, etc., and we could go into a lot about that. So how does that fit into the current psychological thinking on trauma in terms of, you know, maybe from a practitioner's perspective and also from an academic perspective? Yeah.
From an academic perspective, I suppose there's increasing knowledge about the impact of intergenerational trauma. So, you know, sometimes there's a lot of emphasis on genetics, and I always say just, you know, be careful around that, because there's a lot of things where we've said, you know, there's a genetic reason for that, but then nobody can show you the gene. But what we do know from epigenetic studies that are ongoing is that the impact of stress, toxic stress, which is a trauma, can be so profound on the way in which you're, you know, and Alan talked about that, about, you know, we'll say risk for cancer. So it can be so profound on your body that there's, you know, research coming out now that it does have, it can have the potential to have genetic changes that affect DNA. What's probably much more likely, though, is how we pass behaviors from one generation to another, or feelings, or untold stories, but they're attached to behaviors. And anyone who's heard me talking before, I've used a very benign example about, I have a child who's frightened of escalators. And I went to the, you know, shopping centre with my mother, and we came to the end, and she said, you know, don't think, just jump, Mom, and we get off the top. And I told my mother, I said, look, she's frightened of escalators, but it's my fault because I'm frightened of escalators. And then my mother says, well, I'm frightened of escalators. But my grandmother, who I had never met because she died before I was born, had seen a small child fall in an escalator and their hair got pulled out. So she had told all of her children that story, her 9 sons and 5 daughters. And then they went on to have a whole host of children. I'm one of that generation. And now we've gone on to have a whole host of other children. Very bad for the environment we are. But what's interesting, you know, from a psychological point of view, is you have a child in the 2020s who's frightened of escalators because something that happened to a woman in 1973. So that's a story that has impacted on a behavior too, and it's very benign, very benign. So when you think about some of the things that have happened in our national history in terms of, you know, you've said about post-conflict, and then things that have happened in homes.
Absolutely.
Things that have happened in institutions, stories that were never told.
Yeah.
But there was a behavior or a feeling that came with it. So, you know, I can look at that example and I can say, okay, now we understand why we behave like that. And that's somebody else's crap, actually. So we need to, like, maybe not worry about it. But then how many of us then are walking around with what I call a backpack of stuff, where we're carrying around stuff that happened to other people, but we were never told the story, but we might have lived in a house with a behavior that we learnt from somebody else that's normal within our family system or our family structure, and that perhaps maybe is not helpful. So there are things that were very taboo in Ireland, child sexual abuse, domestic violence. We still have a way to go with some of those things. But like, I'm coming up on 50 now, and the difference now between our ability to talk about mental health and harm and how we are reducing stigma in so many areas in comparison to when I was a teenager, when nobody spoke about mental health, nobody spoke about abuse or domestic violence or parental drinking. We have come a very long way in a very short space of time. And in the last couple of years now, you have, COVID was terrible, but one of the things that came out of COVID was webinars and podcasts. And we did a study on that here ourselves, and we know that that has made an impact on mental health literacy and on help seeking. People are saying, actually, there's all of these people out here who've had the same experiences as me. I am going to go and get help too.
Brilliant. So eloquently put, Sharon, and what a, for your own family system, I don't know how benign that story was because it's carried on, but I know why you're using the word benign. Well, at least I think I do, in terms of all the other traumas that are out there.
Yes, and it wasn't a trauma that happened to somebody in my family. It was somebody who witnessed something that happened to somebody else. You can imagine it was not benign for that child who fell in that escalator and who got very badly hurt.
Yeah. Thank you, Sharon. Thank you. And Alan, in relation to any remarks on that around the intergenerational?
I think Sharon summed that up really well. And I suppose from a counselling perspective, not to sound really glib about it, but the adage, like, hurt people. And I think that carries on generationally, and I totally agree that it's probably, in my experience, since probably the millennium, Ireland is a completely different country now. We're so literate in talking about this stuff, whereas, like, I suppose how the National Counselling Service was set up was basically came out of breaking the silence of institutional abuse and clerical abuse. So it's not that long ago. The National Counselling Service is only 22 years in existence, 23 years maybe. So we're a different country, and thankfully we're so much more literate with it, and we're able to recognize that it's not okay to pass on these traits, and to get rid of that old adage that, well, what was good enough for me is good enough for you, and just to really question that and take stock of that maybe it's not.
Yeah, there's something very progressive about both of your messages in terms of where we go in terms of service provision, but also the understanding of trauma and developing the idea of trauma-informed care more universally, universally, but also specific to the provision of services in Ireland in the months and years to come. So do either of you want to just offer a few closing remarks before we head to wrap up? I want to take this opportunity, both Alan and Sharon, to thank you so much for participating in the webinar. It was a very illuminating and lively discussion, and I found I resonated with a lot of the points being made, and no doubt that the participants at the webinar did too. So just over to you to offer any concluding remarks before we finish.
All I'd really like to say, Stephen, it's been a pleasure. Thank you so much for inviting me on, and it's been a pleasure to listen to Sharon as well. I would make a plea to anybody who's on the webinar, who is suffering, who is struggling, that it's okay to reach out for help. It's not okay to suffer in silence. Help is there. We're not perfect, and we do have a waiting list, and most services do have a waiting list. but, you know, tell your story. You know, your story is really important, and it is healing, and it absolutely will have an impact on your life. So I would just implore anybody who's on this webinar who is suffering or struggling to reach out.
Thank you, Alan. Thank you. And Sharon?
Yeah, just to echo what Alan has said, and I suppose some tips from my own experience of I love going to talk therapy. I treat my mental health in the same way that I do my physical health. So if I had, you know, a niggling pain in my foot and it was going on for a while, I'd say I better get that checked. And it's the same with my mental health. So if I think, yeah, the mood has been a bit low, I'll go and get it checked because I value them both equally. But I suppose from my own learning is that and I hear this from people that say, oh, I tried counseling and it didn't work for me. So maybe it wasn't the right time at that time. Or maybe it was, you know, connection and relationship is really important. So, you know, so uh, you can go to a couple of people or you can go to somebody and just say, I don't click with them. And it's back to something that Alan said earlier about, you know, sight, sound, smells. A name can be a trigger for somebody, or it could be, you know, it could be somebody's facial features, for example, and you might not even be connected to that, but you just don't feel comfortable with the person. And it's not that they're a bad clinician. It's just not working for you. And that doesn't mean you're wrong or they're wrong. It just means this is not working. And then you find somebody else. So I would have gone to 4 or 5 people before I found the person who was for me. And then that would be a service person I would go to see on and off for the last 10 or 12 or 15 years or something, whenever I feel like I need to do like an NCT on my mental health. So just that if you feel it's not working, it's not that it's you, it's just there's something about this. And then, you know, if I went to a restaurant tomorrow and they served me a meal and everybody liked it, and I was like, I'm not mad about it. It doesn't mean there's something wrong with the meal, but I'm certainly not going to go back. You know, so it's just about, you know, feeling strong enough to be able to make those choices about what works for you. The other second biggest question, and Alan probably would agree with this as well, is a lot of people can contact somebody saying, I'm worried about a family member. How do I help them? Actually, you help yourself first. So you can't always, you know, so rather than trying to shove a family member into counseling when they don't want to go, maybe you go. And maybe you learn some ways of helping that family member.
Resource yourself in terms of helping. Yeah. So just to sign off from myself, to thank you both once again, and to signpost or flag different services. And I suppose it's important in terms of trauma. So for anyone in the audience who's experienced childhood trauma, including neglect, you know, I'd encourage you to reach out to the HSE National Counselling Service. And the number for that is 1800 234 111. If you wanted to go to a non-governmental organisation in terms of sexual abuse, 1in4.ie are another organisation that provides specialised counselling services to people who've experienced abuse and trauma in childhood. We also have our own wide range of services. Our support line is open 10 a.m. to 10 p.m. Monday to Sunday, 365 days of the year. And we have a wide range of support groups for people who are experiencing depression and bipolar disorder, which may be of benefit to you, for those in the audience who want to reach out for support. So go on to our website, aware.ie, for further information about the supports that we provide to people who are experiencing those mental health conditions. And lastly, just to signpost, often at the end of webinars, we recommend people, if they've been impacted, you know, and if you have a good relationship with your general practitioner, perhaps, and you want to have a conversation with that person, to avail of that support too, if you've been impacted or resonated with any of the material discussed today. And lastly, to give a shout out and to promote our August webinar, and the title of which will be Attachment Styles, and that's been discussed this afternoon already in part, and relationships. So the title is Attachment Styles and Relationships, and the guests will be Dr. Muireann McNulty, who's a principal clinical psychologist, and Dr. Emer Farrell, who's a senior clinical psychologist. And the date of that is Wednesday, the 14th of August, coming in 4 or 5 weeks' time at 12 noon. And to sign up, you can get further information on our website, aware.ie/webinars. And just to wish you all a very pleasant afternoon. I think the weather is brightening up where I am here in Dublin, and to wish you all a lovely summer ahead. And thank you again to Dr. Alan McDonnell and to Dr. Sharon Lambert for their expertise, their time and their wisdom on today's webinar. So, Guramaha Gwyth Gilair.
Thank you, Stephen. Thank you, Sharon.
Thank you.
Thank you.